Onc Live Insights is a video editorial program produced by Onc Live.
Much of the progress that's been made in breast cancer over the last few years has really arisen because of this recognition that breast cancer is not one disease, but it's actually several different subtypes of cancers. And each of these cancers has their own molecular features, their own drivers, and it's this recognition that each of these drivers can be vulnerable to a specific drug that's led to a lot of the progress we've had. We have already made a lot of progress with hormone receptor positive disease with estrogen blockers, and that's been something that's been around for a long time. But I think more recently we've seen a lot of success with HER2 directed therapies and just starting to see some benefits in triple negative breast cancer as well. The hard part there has been trying to identify what is the target that's driving triple negative disease. So there really has been progress, and it's been predicated on this idea that breast cancer is not one separate disease, but actually many.
As you know, there's many types of breast cancer. The three main ones are the hormone-sensitive breast cancers, triple-negative breast cancers, and HER2-positive breast cancer. The latter two are less common than the ER-positive ones, which end up comprising 70% of what we see. But now, with targeted therapies, which some of them are very old, like hormonal therapy, play an important role in how we treat these diseases. For the most part, estrogen-positive breast cancers have a fairly good prognosis. They tend to be more indolent. Most people do well with endocrine therapy alone sometimes. And even if they have a recurrence of their cancer, they can still live for many years with current treatments. Triple-negative breast cancer, unfortunately, is not so good. That's a disease that tends to be very aggressive. If there are recurrences, they tend to happen very quickly. Unfortunately, we don't have any targeted therapies nowadays that we can use against these cancers. Chemotherapy is as good as we know to do for them. And unfortunately, when patients recur, they don't live that long. The median average of survival is about 2 years. HER2-positive breast cancer is, I would say, the poster child of breast cancers right now, because even though these are very aggressive cancers, thanks to targeted therapies against HER2, this natural history of disease now is very different than what it used to be before medications such as trastuzumab or other targeted agents against HER2. And now we know so many that work well, and even when patients do recur, again, they may live many, many years with a great quality of life thanks to some of these targeted therapies. Being able to profile breast cancers into ER-positive, HER2-positive, and triple-negative cancers plays an immense role in how we treat these patients, how we choose therapy, and how we can counsel them on what their prognosis and outcome will be.
So one of the ways that we're trying to define different subtypes of breast cancer and therefore potentially tailor our therapies to those subtypes is go beyond the initial three major subtypes of breast cancer, the ER-positive, the HER2-positive, and the triple-negative, and start looking at the genetic level of are there particular mutations in a individual's cancer. Fortunately, the technology is now becoming accessible enough that this is possible outside of the research setting. There are commercially available genetic tests that, based on next-gen sequencing technologies, allow one to look at the somatic mutations, that is the mutation that occurs within the tumor, not an inherited mutation, and define what is potentially at least driving an individual's tumor.
Some of them are done in the early setting, such as recurrence score. Some of them are done in later setting, like next-generation sequencing. In the big scheme of things, from a standard care point of view, the early ones are now approved by the FDA, and they're actually very helpful in decision-making in terms of treatment, because not only they're prognostic, but they're most importantly predictive of how we're going to treat patients with breast cancer. With the recurrence score or Oncotype DX, we are able to test patients that have ER-positive breast cancer, early breast cancer, stage 1 or 2, where we're not sure if they really do need or don't need chemotherapy, if they can do well with just endocrine therapy by itself. And therefore, this is a wonderful platform to tease out who's really going to need more aggressive treatment or not. It tells you if the cancer is much more sensitive to endocrine therapy versus a bigger need for chemotherapy. So this is now approved, and we use it quite often. And it really has revolutionized treatment for a lot of people, where we're able to treat just right rather than over-treat a lot of these women. Now, in the metastatic setting, there's really not a platform that really has become quote-unquote standard of care. Some of us are ordering next-generation sequencing to profile some of the tumors, but I can't say that that this is a standard of care thing, precisely because a lot of the answers we get from this molecular profiling may or may not be actionable. And sometimes what we see as actionable is actionable within a clinical trial. So I would hesitate to recommend that everybody should get next-generation sequencing done in metastatic tumors. But on the other hand, I think it's actually very helpful in order to guide us to treat patients within a clinical trial or not, based on what we find in terms of molecular profiling. But from the day-to-day standard of care drugs, a lot of this next-generation sequencing profiling may not be helpful. So it is not by all means something that it is standard of care today.
But again, I think it's important for people to realize that right now there is no real mutation that says, okay, this is a patient who should get an FDA-approved specific therapy. It's really, for the most part, confined to research purposes. But I think this is going to change over the next few years. There actually are several clinical trials going on, both in Europe and the United States, which are really trying to ask this question of whether a particular mutation found by next-gen sequencing can predict sensitivity to an inhibitor of that mutation. These trials are just getting underway, but I think within a relatively short period of time, we will have some information. And I think many of us are optimistic that at least in some circumstances with particular mutations, a mutation will tell us that a specific drug should be used in that patient.